Hi, everyone. I'm Dr. Stephan Mayer. I'm professor of neurology and neurosurgery at New York Medical College in New York.
It's John Rosenberg, assistant professor of neurology and neurosurgery, Westchester Medical Center, New York Medical College in New York.
And we're here today with Dr. Christopher Kellner. Chris Kellner is a pioneer in minimally invasive surgery for intracerebral hemorrhage. And we're going to pick his brain today about where the field is now and where he thinks it's going to be going. Dr. Kellner is associate professor. Is that true, Chris?
Assistant for now, associates in the works.
Okay. Up and coming associate professor at the Icahn School of Medicine at Mount Sinai. And he's based in Mount Sinai West Hospital in Midtown Manhattan, which is actually a kind of very unique practice setting. It's a hub for intracerebral hemorrhage for your system. Isn't that true, Chris?
Yes, it is. We have done our best to build a intracerebral hemorrhage center at one of our major hospitals in the middle, right in the middle of the city.
Super cool.
So welcome back to the podcast, Chris. It's good to see you. So, for many of our listeners are kind of at different levels of training and new to the subject. Maybe set the stage for us. Tell us a little bit about where the field was about minimally invasive, how the field started with maybe the MISTI trial, minimally invasive surgery for ICH evacuation, and then taking that, maybe the lessons we learned and what the next steps were after that.
Thanks a lot, John, and thank you, Stephan, for inviting me here to speak on a topic that I'm very passionate about. So happy to talk all day about this topic. Well, let me start by saying how I came into this and why I've been focusing on this. And when I was in my fellowship at Mount Sinai as an endovascular neurosurgeon in 2015 to 17, Dr. Jay Mako and Josh Betterson and Stanley Turum, who was here in neurology at the time, and Stephan, I think you were here even at that time as well. People were started talking about setting up an intracerebral hemorrhage program that would focus on improving the care of these patients and centralize the patients at Mount Sinai West, which is one of our hospitals that has an NSICU. And by focusing patients there, we were hoping that we would be able to improve the care for those patients by acclimatizing everyone to this patient population, the surgeons, but also the nurses and the ICU attendings and the physical therapists and the social workers, because these are patients that have a very specific set of needs. And so by doing that, we were able to really increase the volume and centralize it all in one spot to maximize our learning over time and maximize the efficacy of our protocols. And so we have created a policy where if an intracerebral hemorrhage patient comes in to any Mount Sinai hospital or any of the affiliated hospitals or any referring hospital, sometimes those can even be very far away, we'll send them to Mount Sinai West and then take care of them there. And part of that program has been trying to figure out if minimally invasive surgery is an effective treatment for these patients and what specific procedure we can do for them. And so when I was hired, Dr. Mako asked me if I'd like to focus on this particular disease process. Of course, as a neurosurgeon, I said, well, what about aneurysms and what about AVMs? And he was like, I can't promise anything about those, but you can take care of all the ICHs. And so I took that eagerly as an opportunity to try to make a difference in a field where not a lot of people have focused on, at least from the neurosurgical perspective in the past. And so to answer your question more directly, how did this field start? I would say that it started a long, long time ago, around the time I was born in the early 80s. There were a bunch of studies looking at a MISTI-like approach, and those studies paved the way for MISTI, showing the safety or some early safety data on catheter placement with thrombolysis. And in the early 80s, there were even endoscopic papers showing some early data and even a randomized clinical trial from Austria, Auer et al., showing safety and perhaps even a little bit of an efficacy signal in endoscopic evacuation for deep and lobar hemorrhages. And so those early papers paved the way for larger studies in the future. And I see it really as a parallel track of a whole bunch of minimally invasive studies happened, while also in parallel, a bunch of open studies where open craniotomy and evacuation under a microscope, or surgeon's choice. And surgeon's choice often will be open craniotomy with loops, which are just, surgical glasses with some magnification, or a microscope. And we know from those early studies that it did seem like there was a signal in the minimally invasive studies all the way up to the present day, although there was no really high quality study performed up until MISTY-3. And the studies in parallel occurring in open procedures all appeared to be negative over time. And so that included many early studies, and then Stitch 1, and of course Stitch 2, published in 2013. So really up until then, the open studies weren't working out overall, although there are a few little nuggets of information in the history if you really dig into it. And while in parallel, the minimally invasive studies did seem to have some signal over time. And those little pieces of information that we learned that built the premise and foundation that MISTY-3 was built on, and also Enrich, and also some of the other trials that are occurring right now. Those studies were summarized in a few meta-analyses. One of them was by Zhou et al., Z-H-O-U, and that was published in 2013. And then our group even did an update on that with the same methodology, looking at minimally invasive studies from 2018. And we have repeatedly shown, as medicine has shown, that it does seem like the minimally invasive procedures overall are working. And it's only now recently that we've got now level 1 evidence to show that it does appear to be working in the cortical hemorrhage group. And we eagerly await the results of the Enrich study to show that specifically. But to talk about now more modern day, as in 2019, with the MISTY-3 results, I think everyone was excited for that trial to be positive. I think anyone who's done that procedure and cared for those patients have seen some really big wins with the MISTY procedure. And we were waiting to see which groups does it work in? Does it work in everybody? Does it work in the deep bleeds? And I thought that trial was probably going to be positive, and it was negative. But we know that there was a subgroup that was a pre-specified subgroup analysis in the patients in the, quote, intention to treat, as treated analysis. And by as treated analysis, that's the patients who met the surgical endpoint. So the intention to treat analysis of all patients enrolled in the surgical group and the medical group, that did not work out. And we know that that was a negative overall primary outcome result. But one of the secondary outcomes that everyone was focused on, the as treated analysis, were about 60% of the patients who met the surgical goal of leaving no more than 15 cc's at the end of treatment. End of treatment not being the surgery itself, but being a combination of the surgery plus the multiple days of thrombolysis given regularly in the ICU. Those patients who met that surgical endpoint, they did have a benefit overall at the 1 year endpoint. And so Chris, that let us, yeah.
Sorry. If you don't mind, break down for our listeners, because I'm not sure everyone listening is going to really know what is the MISTY procedure and how does that differ from the kind of surgeries that you do and what was performed in Enrich with the endoscopic approach.
Yeah, you got it. These are a few very different surgical approaches to the same problem. The MISTY approach is when you stereotactically place an EVD catheter into the hematoma. So normally using stereotactic guidance in an operating room, you would be placing an EVD into the ventricle, and the computer would guide you into the ventricle, showing you exactly where to go, what trajectory to take. In the MISTY procedure, you are stereotactically placing the catheter into the hematoma along the long axis of the hematoma. And a lot of training went into how to do that in the correct way. And that was built off the evidence built in MISTY-2 and prior studies. And then you lightly aspirate whatever will come out easily at the moment of catheter placement. So there's some aspiration right away that occurs. And then a repeat scan is performed to show that the catheter is in the correct position. And then I don't remember all the details about exactly what the timing is of additional scans, but I think approximately 6 hours, another scan is done. And then TPA is given at that point if that scan shows that there's been no new bleeding and the catheter's in the right spot. Then TPA is given at regular intervals over a maximum of 4 days with repeat scans occurring. And so that's the MISTY procedure. Endoscopic is kind of the next level of invasiveness, where the MISTY procedure is the diameter of the EVD catheter, which is 2 point something millimeters. The diameter of the sheath used in endoscopic procedures is 6.3 millimeters. So it's a larger tract that you're making, but you're giving yourself direct access to the hematoma so that you can do a active evacuation. And by active evacuation, I mean you're in there and you're actively aspirating the clot and you're working to remove all of it right up front. So you've got a larger tract to get in there, you're doing more work in the moment, and you're trying to create a good result with everything done right there. You're not leaving a catheter in after, you're not giving TPA after, you're trying to do it all at once. And so what you do in that case is you put a 6.3 millimeter sheath in stereotactically, then you put in an endoscope, and then down the endoscope, you have a working channel. And through that working channel, you're putting in an aspiration device. And if you need to, you can even put a cautery device down there. So if you see something bleeding, you can handle it. And the really nice thing about that that's different from MISTY is you don't need to screen the patient to make sure the hematoma is stable. You can go right in right away. And if there's a spot sign on the CTA, you can even target that stereotactically and try to go right to that and cauterize that right from the beginning. So it gives you a broader set of patients to treat with the procedure and perhaps even mitigate expansion of the hematoma if you get in there quickly and address the bleeding. Then the next level of invasiveness is endoport, and that is a 1.5 centimeter port is the port that was used in Enrich. And so that's more than 2 times the diameter of the endoscope sheath. And what you're doing there is you're putting that port in. That procedure requires a small craniotomy. And then you get a microscope and do a sulcal dissection. So you split the sulcus, whatever sulcus you're on, and then you place the endoport at the depth of the sulcus, stereotactically guided into the hematoma. And then you lock it in place. And with a bimanual dissection, you're using your left hand with a sucker and your right hand with the Myriad aspirating cutting device, or with a regular sucker or a bipolar if you need to stop something from bleeding. So the nice thing there is that you can work with both hands like you do in regular neurosurgeries. It requires a little less training than endoscopic and is easier to address bleeding because you've got a regular bipolar. So that's kind of the summary of each of the procedures for those of us who are not surgeons, which I think is probably most of your audience.
That was a fantastic
That's
summary.
a great summary,
Thank
really.
you so much.
Okay.
Really.
Okay. Well,
I think let's jump into your thoughts of how you approach an ICH. Who do you look to take? Population, demographics, timing of surgery, location. What's your thought process when you're getting consulted about these patients?
we've had an evolution in thinking over time, mostly around the timing and the requirements related to being eligible for the procedure. But let me go all the way back to right when we started the program back in 2016. And these were a set of criteria that we derived in a multidisciplinary group based on the meta-analyses that had been performed. At the time, we didn't have Enrich, we didn't even have MISTY at that point. So we came up with our criteria from the prior meta-analyses. And so a minimum of 20 cc's as a low end, and then an NIH stroke scale of 6 or greater. And that's basically derived from the stroke literature, where if somebody's a low NIH stroke scale, they probably don't merit the procedure because of the risk of the procedure. And so we're using 6. And then in terms of age, not having an upper age limit, but the procedure being based on the patient's baseline neurologically and what their wishes are, rather than stating an upper age limit. And then in terms of the size of the hematoma, no upper size limit, just treating the patient if it seems like the right thing to do and seems like something feasible with a minimally invasive approach. So no upper size limit. And then we have a screening procedure. So just like any stroke patient coming in, they get a CT and a CTA. And that CTA has to show no aneurysm and no vascular malformation. You can't do a minimally invasive procedure and risk getting into one of those. So we need a negative CTA. And then if there's any question on the CTA, any abnormal vessel beyond a spot sign, or if the patient's young with no hypertension, then we'll do an angiogram to rule out a vascular malformation or an aneurysm. And so that's the general criteria. And then in terms of timing, early on, we were doing them within 72 hours. And that's what a few of the studies that were derived around that time were using for enrollment in the studies. And so that's what that timing was based on. But over time, we've seen in our own data that it appears that the patients who are being treated earlier with this are getting have a higher probability of a good outcome. And we even published that in Stroke in 2020. And so what we'll do now, and what we've been doing for a few years, is we will treat these patients exactly like an ischemic stroke. If they have a CT and CTA showing an Aspect 10 and an LVO, then they're going to the angio suite and they're going to get a thrombectomy. If they have a large hemorrhage and they have a negative CTA, then they're going to the angio suite and they're getting a minimally invasive evac. And so we have been doing that for a bit now, given our interpretation of the timing data, which is pretty robust in the literature now, which we summarized in a recent review. And so that in our own experience is very convincing that this is really a time-based effect, and that we really feel strongly the earlier the better. And I'm really looking forward to getting a good data set of the 0 to 6 hyperacute period, because I think who knows how good you can get if you get into that window. There's not much data published on that, except for one case series out of Taiwan from 2011, where they treated 68 patients in the early time window. And a large percentage of those were ultra early within 4 hours, and they had extremely good outcomes in there. So hoping to repeat that experience and see how that works with the endoscopic procedure we've been performing.
So just to reiterate then, so you're do you have like no minimum time window? Do you wait for a stability scan, or you simply just go on the baseline non-con and CTA?
That's a great question. And for a few years early on, we were waiting for a stability scan because we were enrolling patients in a registry or a trial. It was a single-arm feasibility study called the INVEST registry and trial. And that did require a stability scan initially. And until our own data and other people's data showed that you don't need to wait for a stability scan when you're doing an active evacuation in which you can reliably treat bleeding. So I would say that early on, before we knew that bleeding could be treated endoscopically or through an endoport mediated approach and now a surgiscope approach, we were hesitant to rush into patients that weren't stable or that had spot signs. But now I know that can be handled in every single case when you encounter bleeding. And so now we are not waiting for a stability scan. We're not waiting until the CTA clears up with no spot sign, but instead seeing that seeing expansion and seeing a spot sign and seeing an early patient as being an opportunity to get in there with an active approach and address the bleeding to prevent that expansion from happening.
Great. Let me ask you another question. And so, as many of our listeners, maybe not all will know, the ENRICH trial was recently published, and they took an interesting approach. They were looking at, good-sized ICHs, and they were initially randomizing the deep ones and lobar, and they had a pre-specified rule that they would do an interim analysis, and they basically stopped enrolling the deeper bleeds on the basis of futility. There simply wasn't enough signal. They went on, continued to randomize several hundred of the lobar bleeds, and when they broke the data set and stopped enrolling, there was a very nice shift towards better outcomes across the range of rank and functional outcome levels. Are you surprised at all by that finding? Because I'm pretty sure, remember that you would go for like those 30 to 40 ml putaminal bleeds, and showed me some cases that were getting good results. Some of them, I remember a conversation where the hemiparesis was like much, much better just 24 hours later, and you thought it was just reduction in wall tension on the capsule. So I'm curious to hear your thoughts about how that trial shook out and where you think it might be going? Are you still going to be treating the deep bleeds now?
Yeah, I think that trial showed us what we saw in a signal for in stage 2 and in stage 1, that lobar hemorrhages seem like they respond a little bit more than basal ganglia hemorrhages to surgical evacuation. And it's going to be really interesting to see, can we identify other factors in the basal ganglia bleeds in the enriched data set that would give us a hint that that's why the procedure didn't work in those patients, such as time to evacuation or evacuation percentage. Maybe it's harder to completely evacuate basal ganglia bleeds with the end-of-port technique. I don't know. I'm really looking forward to seeing those multivariate analyses of each location. But I think that what I've heard some people say is that perhaps the deep bleeds require a less invasive approach. And some evidence supporting that thinking is, I believe there was not a location-based difference in the MISTI approach. So the MISTI data had basal ganglia hemorrhages and cortical hemorrhages. And in that subgroup analysis I was mentioning, where 60% of the patients had less than 15 cc's at end of treatment, there was not a location-based effect in the MISTI procedure, to my knowledge. I haven't seen that subgroup analysis come out of that study. And so I would say that it seemed like in that subgroup analysis, when less than 15 cc's was met in MISTI, it seemed like they had a good effect across locations. However, we didn't see a good effect across locations in ENRICH. And so we really need to dig in the data and see if there's any hint there why. But it might be about the degree of invasiveness of the approach.
So just two quick questions. Do you think it possibly just less disruptive with you could have more disruption of the subcortical U fibers with a more invasive approach? Is that what you're saying, Chris?
Certainly possible, right? You could lose an effect in some patients in which you have to travel across some degree of depth and some increased number of fibers to get to the lesion. So that certainly is a possible explanation.
Yeah.
What do you tell us a little bit about where you think the future of minimally invasive surgery is headed?
I think we've got to take serious the pressing time effect and understand what the differential of time is. And we're going to see that from the ENRICH data. Is the ENRICH data driven by those early evacuations? We don't know yet. We were waiting for that paper and that subgroup analysis. But I think I think we're moving towards a emergent procedure, and we're moving towards technological advancement in which we can reliably always get all the clot out and always stop the bleeding early. I think once we've got all those things figured out, we're going to have a strong treatment effect across locations.
Mm. I've been so impressed with what you've been able to do and your approach. How much penetration has this kind of aggressive use of minimally invasive surgery, and in particular in earlier timeframes, how much penetration have you seen across the United States so far? And how does that compare to, let's say, other parts of the world like Japan or Europe?
Great question. I feel very fortunate to be in an institution where there's a multidisciplinary collaboration supporting this type of management of these patients. And that's not universal, obviously. I think that the penetration is low right now. I think a minority of centers, mostly academic centers, are performing minimally invasive surgery as a standard of care for any location. After the ENRICH data comes out, I'm sure that's going to increase significantly, and there will be more cortical minimally invasive evacuation. So I think I would just say penetration is low at the moment and will increase significantly in the next few years as people start doing cortical minimally invasive as more of standard of care across institutions, academic and non-academic. But we do know that minimally invasive evacuation has been standard of care in numerous Asian countries for many, many years, in some decades, and even included in their guidelines. So I think we're sort of kind of catching up to the way this has been done in China, for example, doing craniopuncture and publishing a really strong randomized trial in 2008. And then in Japan, doing endoscopic assist over the last few decades. And in Taiwan, I mentioned that paper, they're ultra early. Exactly what I'm trying to do here now was done there for many years and published in 2011. So that was quite a long time ago.
And just to clarify for the audience, you're still doing your procedures now in the interventional suite, is that right?
Yeah, we've found a good home in the interventional suite because we have multiple rooms under our control in Mount Sinai West. So there's always a place to go with the case. And we've got a really great combined team where the IR tech has taken a leadership role in setting up the equipment in the room and helping manage the patient during these cases and the imaging during the cases. And then we've got a great OR team coming down to provide the OR tech support and the nursing support. So I think having a great team, having a room available, and then finally having the ability to do an intraoperative CT right on the table and check how much is left. Have I met that 15 cc target? Or was there something unexpected that I didn't pick up on through the endoscope? About 20% of the time, I am going back in for a second pass is one way to think about it. You know, you do multiple passes in thrombectomy. In minimally invasive ICH, you do one pass, see how much of the hematoma you got out, do a CAT scan quickly, don't close anything, but remove the device, put a sterile towel over the field, do that DynaCT on the table, and then review that, calculate the residual volume, and see exactly where it is in 3D space, and then go back in and target that if necessary. For me, that happens about 20% of the time, but I find that's extremely helpful to know what I'm coming out of the room with and how safe I feel that patient is, and I know that I can be done with the procedure. Know that I'm completely done with the procedure.
You'll pull the endoscope out, get the scan, and you'll just go right back in through the same trajectory.
Yeah. You really can't go through a separate trajectory. You know, you've got the hematoma there, and you just go through the same trajectory. And then once you're in the hematoma space, the cavity, then you'll direct towards the residual hematoma that you saw on the CAT scan.
Got it.
Thank you so much, Chris. This was fabulous. I think if I could summarize a little bit of nugget of information of what you said, a nugget of wisdom for our audience, it sounds like even at this point, the field of minimally invasive surgery for hematoma evacuation is quite young, and you're most interested in optimizing timing to surgery, techniques for hematoma evacuation, and less dogmatic about location at this point, because I think there's still a lot more to understand as our technology and as our throughput gets better. Is that a good summary of your approach?
Yeah, great summary. I think we've seen some hints in the literature that this can work in deep lesions as well as in cortical lesions, and we've got to do all the things we know that make this procedure work, which is get in there early and get all the blood out.
Great. Okay, so wrapping up again, thanks so much to Dr. Chris Kellner from Mount Sinai School of Medicine and Mount Sinai West. Again, I'm Stephan Mayer.
John Rosenberg.
And we're signing off with the master class of the NCS iPod series.
All right. Take care, guys. Thank you so much.
Thanks, everybody. Bye.